All right, folks. It's going to be the IM overview, just kind of some random ramblings on what to expect and kind of how the rotation itself goes. Really good, for the third year medical students just starting out and auditioning fourth years that are kind of new to the program, just so you kind of know what's going on. So, oh. All right, so first thing, kind of start time, finish time. We get there 6 a.m. is sign out, and then 5 p.m. is sign out. So those are the times that you are expected to be there. You're expected to be there from 6 a.m. to 5 p.m. Um, that time is very variable, especially the sign out time, especially as a student, very variable. With that, you might be done at 3 and you might get to leave a little early. You might not be done until 7. You might be staying a little late. The sign out time in the mornings, the 6 a.m. sign out. That's whenever we kind of receive the patients from the night float team. So as a student, I remember I would get there before that sign out. I would look up all the patients that I had, ahead of time, already knew I had from the day before, and kind of get started from that standpoint. Not something that you have to do, but just basically do whatever you need to do to make the day flow easily for you. If that means you need to get there a little early, if that means you need to stay a little later. And then, the last but not least thing on this is also just how busy you are as a team. If there's 4 students versus 1 student, will kind of vary on when you get done. The more students there are, there's more notes for the residents to go through. So if you end up being last in that line of students getting their notes reviewed, you might end up being there a little later. So expectations, just like everything else, show up on time, want to learn and try hard. Not a lot going on there. Just what to do. Just do what you've been doing to get you to this point. The next thing is the IM COMAT exam. If you're a third year medical student and you are a core student, you'll be taking this. Remember, there is a study guide on the S Drive, as well as all the other review course material that we're kind of going over. It should be, to me, it's a pretty difficult exam, just because it's just a lot of info. So prepare, work questions, read. There's a lot of good review books out there. The Mayo board review book that we use is really good if you are able to read, a 1,000-page book in a month. But remember, you kind of get a little bit decreased yield when you're having to read that fast. So, just do what you can for that. Usually we try to give you a little bit of time, kind of there toward the end, maybe the day before, a day or two before, let you out a little bit early. So just let us know if you have that coming up. Because, for every school it varies. So don't expect that we will know that you have your COMAT exam that month. Let us know. The next thing is the Mayo test or Mayo quizzes. Remember, these happen every week. And if you're a fourth year, rotating student, this is just a quiz we take out of the Mayo board review book for internal medicine. And they're 50 questions each. They'll kind of refer to them as a quiz. And I remember thinking, oh, it's going to be like 10 questions. But no, it's a 50 question basically test. You don't have to do the best as a student to kind of avoid outlining the chapter, so that's kind of the punishment if you do bad. If you do poorly, I think for students it's like a less than a 50%, which you make a 50 on the test, then you have to outline the chapter. But if you're auditioning here or you want to come here for residency, it's always best to try to do well on these. And of note, we have had students in the past have basically the highest overall quiz average, meaning out of everybody in the residency program, the students could score just as high as the residents. So definitely something that can be done. Just read the chapter. There's back of the book questions from the 10th edition, 8th edition, 9th edition, and you can find all that stuff on this drive. Procedures at the beginning of the year. So if you kind of rotate, July, August, September months, the interns are going to be getting all the procedures, so you might miss out on procedures. If you rotate a little bit later on and you're a fourth year, we'll try to work you into some procedures. If you're a third year, it's usually just kind of getting you familiar with the procedure itself, maybe practicing on the dummies and stuff like that. The Procedure Pro app, so Pro app is really good. It's a couple gigs. I think it's like a 1.5 or 2 gigabyte app. So you gotta have space on your phone. If you don't have the space, I would say maybe get the space, watch all the videos, and then delete it. Also, just YouTube. There's great videos on YouTube on all the procedures. and you can find everything you need to there. So, and then our notes. This is kind of be where the focus of this talk will be, just kind of talking about notes, what we do, and how to present them to Dr. Pizzamenti and stuff like that. So, history and physical. So, the first thing we kind of want to know about this is that we want to try to tell a story. So, in telling a story, that means it's going to flow logically, and we don't want to basically be reading it. So, you don't want to have your head down, kind of reading the piece of paper to as you're presenting it. You also want to try to keep this thing in chronological order. So you want it to flow logically. You want to try to have it memorized, and this is easier for some and harder for others. Just basically keep reviewing the story, keep practicing it. Go to your resident and say, "Hey, can I talk through this case with you?" And after you do it enough, this eventually becomes pretty easy, and it's not something to really worry about. But early on, it can definitely be difficult. So flows logically, try not to have it memorized, meaning try to be conversational about it, and you want it to flow in chronological order. So when we're looking at that, so you're going to be asked to present the patient, and the first thing you want to do is you want to give the name and the room number, and this is just so the patient can be looked up. So you're going to do that. That's really like number one. Then from there you want to give a chief complaint, and you want to do that a quote if possible. Remember, if they came in altered or unable to provide a chief complaint because they were intoxicated or something like that, that's just you can't provide one. But my leg hurts might be one, or I'm short of breath. Then you want to give the patient's name, the age, pertinent past medical history. Let's say they came in with shortness of breath, COPD, and how much O2 they're on at home would be pertinent there. The fact that they have gout might not be so pertinent. And then the reason for presentation and baseline. So it might be, John Doe, a 67-year-old male with past medical history COPD on 2 liters of oxygen at home, 24/7, comes in for worsening, shortness of breath, cough, fever, and at baseline he's, able to perform all of his ADLs without any difficulty. Or at baseline he's bedridden secondary to end-stage COPD. So kind of understand that little first phrase there. And then you kind of want to present, what led to the hospital stay. So, for the last several weeks, several months, several days, whatever the patient tells you, it could be a 2-day history of cough. It could be a 1-month history of, worsening shortness of breath. There's a lot of little things that can kind of go into that. And, some patients will even, ratchet this thing on back to, 30 years ago, I had such and such, such and such. And sometimes that's pertinent. Sometimes it's 30 years ago they had a motor vehicle accident. That made them a paraplegic, and ever since then they've kind of been getting recurrent, decubitus ulcers or something like that. So, just kind of what led to the hospital stay, and this is kind of the, the chronological order that really needs to flow there. So next is, they either arrived to the ER or they were a direct admission. If they arrived to the ER, you want to kind of sum up what took place in the ER. You want the vitals, the lab work they did, the studies they did. So for our shortness of breath guy up here, presented to the ER with worsening shortness of breath. Labs were obtained and were non-contributory. Vitals were X, Y, and Z. Chest X-ray, showed a left lower lobe opacity consistent with pneumonia. And for whatever reason, they got a CTA and it did not show a PE. So something like that. That would just kind of be summing up the emergency department visit. And then you want to talk about what they were like when you saw them. So then you went down to the ER to evaluate them, or you evaluated them on the floor, and you see kind of a tachypnic male. There's a little bit of physical exam that goes into this part, but you're basically just want to say, it was congruent with the emergency department notes that you received, or it was not congruent. So that you just kind of know kind of the flow of the patient. I was told they were short of breath. I was told they were hypoxic. I was told they were hypotensive. I went down there to see them, and they were sitting up in bed complaining about, the sandwich that they got, and, those type things. Or they were, you went down there and they were legitimately all of those things. So remember, there's a lot of different presentations you can get, and, people can change significantly from, minutes. It could be a little bit of IV fluid and they're up on the edge of the bed doing great, or it could be, they got a breathing treatment, now they feel a lot better. So there's a lot of things there, but you just kind of want to give the logical progression of their visit at this point. So, what led to their stay, then kind of what they did in the ER, and then, what they were like when you saw them, and then your closing statement. Try not to pin yourself in on a diagnosis. So no diagnosis here. So don't put that they were admitted for, pneumonia when you're not 100% sure it might not be pneumonia. Sometimes stuff changes. Maybe just say they were admitted for shortness of breath and cough. And this closing statement is something like, patient was admitted to the internal medicine residency service under attending X for worsening shortness of breath. And, if you want to, you might put likely secondary to pneumonia, but try not to pin yourself in on diagnosis there. Remember, the history and physical is not really trying to, or the history of present illness, this is kind of the HPI part. Not really trying to pin yourself in on a diagnosis. That's more of our assessment plan, but really just trying to present the patient. So going on from there, whenever we're doing our history and physical, you're getting your past medical history, your past surgical history, family history, social history, meds, allergies, review of systems, and physical exam. For physical exam, you need to have the vitals first. Review of systems. This stuff's in the EMR. So it's basically the click system, and you click what's there and click what's not there, and you can kind of expand and type in what you need to. So it's got all the little boxes that you need to cover. So just make sure you cover everything, so you get kind of plenty of tallies and all that kind of stuff like that. Allergies, for the allergies, it's basically what were they allergic to, and then what happened. Was it a rash? Was it anaphylaxis? Those type of things. Meds, these are sometimes difficult to obtain. Do the best you can. If they can provide a medication list, that's great. Most of the time they've already provided this to the nurse. I usually just ask their medical problems. So that I just what do they take medicine for is usually the way I word that statement. And so then I might tell you like hypertension or diabetes, and then you check their medication list to verify this. And if you run across any questions, patients on 2 anticoagulants, or they're on 4 antiplatelets, kind of go clarify there, see if one got stopped recently, those type of things. Social history, drinking and smoking are pretty big. Remember, you also need an amount and how long on both of these. So, they drink 1 drink a day, or they drink, one case a day. They smoke 1 cigarette a day, or they smoke 1 pack per day, and they've been doing it for 1 year, or they've been doing it for 50 years. And remember, you have your pack years, which is just you smoke 2 packs a day for 50 years. That's 100 pack years. So those type of things. Family history. Always just ask mom, dad, brothers and sisters. Siblings, children. Children are good in some of your older patients that might not have brothers or sisters that they can remember, or their mom and dad passed away when they were kind of young, so they didn't know their mother and father's medical problems. Past surgical history, what they had done and when it was done. Very important for your heart stuff, especially like stenting. Was it stenting less than a year ago, more than a year ago? Bypass, those type things. And then your past medical history, like I talked about earlier. You can get this from the patient, old records, call the PCP, whatever you need to do. This is usually kind of pretty extensive. Usually our nurses help us out on some of this, so take advantage of their documentation as well. So, and that pretty much wraps up the HMP, at least the history and physical part of the HPI, or your history and physical. You have the HPI, and then all this other stuff: the past medical, past surgical, social, family, and all that kind of stuff. The assessment plan, we'll talk about that a little bit later. So now I'm kind of moving into the daily progress note. The daily progress note should be significantly shorter than the HMP, at least for the HPI part. So like the subjective part of the exam. So in this part, you really want to talk about what happened overnight. So kind of your overnight stuff. I always like to ask kind of about big things to me. Chest pain, shortness of breath, abdominal pain. And then, stuff for kind of like DVTs, so like lower extremity pain, lower extremity swelling, that's maybe worsened or something like that. If they came in with CHF, then yeah, their lower extremities are going to be swollen, but it's something to think about there. And then diet. Are they tolerating their diet? Are they not tolerating their diet? Have they had a bowel movement? Are they urinating? Are they getting up to bed to chair? Are they ambulating the halls? Those type of things. So just kind of functional status, anything big that's changed, and then their current complaints. Maybe headaches gotten worse, or overnight they developed chest pain, got an EKG that was negative, but they also had a troponin that was elevated or positive. Cardio was called. Those type of things. they had a 17 beat run of VTAC. Those sort of things. That stuff you're gonna have to get from Telly and the nurse. The patient usually doesn't know they had an asymptomatic run of VTAC. Keyword being they're asymptomatic. So, and then you want to get to the assessment plan, and we're going to talk about that in just a little bit. So the discharge summary. This is really, once again, I have the word sum like 3 times. So basically, you're going to sum up the admission H&P. You're going to sum up what happened for the hospital stay. So, my classic little statement is, the summary of the H&P. And that's kind of like my first little heading there. And then, all that info goes there. And then I have a summary of the hospital stay. And then, I have kind of all that stuff there. And then the big one that I think gets left off sometimes is the follow-up. And then I have that as like a separate heading, where we want them to follow up and where what they need to do, lab work, imaging, who to see, whether it's just their PCP and stuff like that. Big thing on this is, what would you want to know as an outpatient physician, receiving this patient from their most recent hospital stay. Try not to provide just too much superfluous information there. You don't want to talk about their toenail and how we consulted podiatry to trim their nails, unless that contributed to maybe diabetic foot wound and then they got osteo and had to have an amputation. You might want to include in that case, but in most cases that's not going to be something included, especially in the guy that was admitted for, shortness of breath. So kind of focus on why they were there, what we did, how they got better, what you're going to do to continue to make them better. So now we want to move on to the assessment plan. So the assessment plan is kind of the big part of this whole talk, and why we do what we do. As physicians, the assessment plan is kind of supposedly how we make our money. So first thing we want to do is, once we have a diagnosis, we want to kind of classify the diagnosis. For like potassium, is it elevated or is it low? So it'd be kind of classifying or increased or decreased. So it's hypo or hyperkalemia. For a lot of stuff, is it acute? Is it chronic? It is acute on chronic. Like you can have an acute kidney injury. You can have chronic kidney disease. You can have an acute on chronic kidney injury or failure, or those type of things. Like heart failure. Heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction. This would be used to be diastolic, and this used to be our systolic. Those type of things. So you want to classify it. So first thing is we establish a diagnosis, then we want to classify that diagnosis. Then we want to say what makes this diagnosis. For heart failure, it's a clinical exam, our Framingham stuff. For hyperkalemia, it might be just our labs. For maybe a pneumonia, it's the imaging, and then along with like a white count and a few other things. Don't just, if they got a patchy area, it could be atelectasis, could be a lot of things. So, and then, their history, how does that contribute? Did they say they had cough, shortness of breath, fever at home, or were they completely asymptomatic and it's just a random finding on chest x-ray? So we'll classify it and we want to say, what makes the diagnosis, and then, every day is what we're trying to treat improving? Is it getting worse? Is it getting better? Is it staying the same? So for someone that came in for heart failure, somebody came in for acute heart failure secondary to a STEMI, diagnosis made by an echo, which showed a EF of 25%. The patient is improving today. Those type of things. So we have an improving, or they're getting worse today. We have worsening heart failure, worsening chest pain, those type of things. And then what did we do today to improve the problem? So today we diuresed. Today we provided antibiotics. We're continuing to treat per early goal-directed therapy for sepsis, those type things. And then what are we going to do tomorrow to continue to improve the patient? So what we're going to do today, what we are doing today, what we will do tomorrow, and then if something changes, how will we change to keep the patient improving? So if a patient continues to have chest pain, we'll contact cardiology and repeat left heart cath to evaluate for, in-stent thrombosis, those type of things. And then how do we need to follow up with the patient? Whenever they get out of here, they're going to need to be medically maximized for their heart failure, and follow up with their PCP as well as a cardiologist and those type of things. So we're going to classify it. We're going to establish what makes the diagnosis. We're going to state, is it getting better? Is it getting worse? Is it staying the same? Then we're going to talk about what we did to improve the problem, what we will do tomorrow to improve the problem, what we will do if something changes. So if they turn for the worse, if their potassium shoots back up, What are we going to do? We're going to give IV fluids. We might give insulin with a little glucose. We might put them on albuterol, those type things. Or might diurese, that type stuff. Might consult nephro, and then on follow up, what we'll need to do. So that's kind of every diagnosis needs to kind of have that. So if we want to look at some examples, it'd be kind of a chronic stable problem example that we see a lot, which would be AFib. So patient comes in with AFib, it's chronic, it's stable, they've had it for 35 years. They have a CHADS 2 score of 3. Really, this should be CHADS VASC now, remember. Or VASC, I forget which one it is, S or C or SC, whatever it is. So CHADS VASC should be the one that we use more commonly. It's a little more accurate. So, but anyway, we have our AFib. It's chronic. It's stable. So we have kind of what it is. We have our diagnosis. It's chronic. It's stable. In this, we can have like paroxysmal. We can have it's not paroxysmal, continuous, whatever we want to call it. So there's a few other little defining words you can use there, but. So we have AFib, it's chronic, it's stable. They have a CHADS score of 3. They're on warfarin. Our goal INR is 3. Their INR is within goal. We're going to continue their warfarin. We're going to continue to follow their INR. Remember, we don't have to follow this every day, so we're just going to follow it. We can just say that we're going to follow it. And then we're going to assess daily for signs and symptoms of bleeding and or acute CVA or acute stroke. So basically that tells you that we know they have AFib. We know what's going on. We know the fact that it's chronic and it's stable. We know what they're on, which is, they're on warfarin. And that their INR is within goal, so they're right where they need to be. There's nothing we need to change, and we're just going to continue to follow them. Something else you might put, maybe they're on tele, maybe we have cardio consulted, those type things. So cardio's on board. Continuing. They might be on a beta blocker for rate control. They might be on amio for rate control. Those type things. So they might be on nothing for rate control. Some people are rate controlled on their own. That'd be kind of just a chronic stable problem. So for an acute problem, like let's say we have acute heart failure. So we have acute systolic heart failure, and this is really a heart failure with a reduced ejection fraction. So we have acute, HFrEF, however you want to say that. I'm just going to say systolic. So we have acute systolic heart failure, like a secondary to the STEMI that they came in with, 3 days ago. They're improving. Sorry. Their echo showed an EF of 35%. Which is kind of contributing to their heart failure. Also, I would talk about the Framingham stuff, how they met the clinical diagnosis of heart failure as well, and which this might be right here. Shorter breath and lower extremity edema is improving. Continuing diuresis for now. Maybe we're still doing it IV. Talk about transitioning to PO, or maybe we already transitioned to PO. We'll medically maximize prior to discharge. ACE, ARB, ACE or ARB, beta blocker, statin, aspirin, those type of things. Set the patient up for cardio follow-up. We're going to provide them a life vest because their EF is less than 35%. And then we're going to need to reassess their EF as an outpatient to see if they need an ICD or something like that. So this could be kind of just a generic assessment plan for CHF. There's a lot more that could go into here, especially like in the medicine end. What medicines they're on, as opposed to just put medically maximized and those type of things. So you do want to elaborate where you need to elaborate. This would be a perfect note for maybe an intern, second year, third year medical student. We might want you to elaborate a little bit more, so you can just kind of get used to knowing and hearing and putting in the note what medicines they're on, so that you don't forget, because it's easy to forget that type of stuff. So when we talk about DC planning, it's just kind of like where they're going to go when they're discharged. So are they going to go home? Are they going to go to rehab? Are they going to have home health? So those type of things. Who's going to care for them when they get there? Can they care for themselves? Can they complete all their ADLs? If they can't, they probably don't need to go home by themselves. Maybe if they have family there, those type of things, that's perfectly fine. And basically, what do they need to do on follow-up? So do they need to get a chest X-ray in a week? Do they have a repeat CBC because they were anemic? You can also talk about leaving the ICU. So this is in every note. We talk about kind of the DC planning. So, and then when can they leave the hospital? So let's say they were admitted. It's our STEMI patient from right here, the heart failure guy. So he's admitted to the MICU. He continued to improve. So our maybe our discharge planning might be something like patients ICU day 3 continues to improve. We'll transfer to the floor tomorrow. We'll continue medically maximization. Transition patient from IV to PO medications at that time. There he will be set up with follow up and provided a rehab. So social services is going to be consulted, those type things, and likely discharge the patient from the hospital in the next 72 hours. Something like that, or transition patient out of the MICU in the next 12 to 24 hours. Those type things. So, and then when they leave the hospital, this is always very, very, very important. Who they're going to see. So, they're going to see their PCP. They're going to need to see cardio. They're going to see endo. Those type things. Surgery, and then kind of when we will see them. So, when is big, and then how are they going to care for themselves? That's kind of another big one that sometimes gets missed. Someone that can't perform all their ADLs. You send them home to take care of themselves. They're going to come back. So those type of things. So now, kind of moving on from there, we're just going to talk about basically some common stuff that we see, on medicine. We hear Dr. Pizzamendi talk about kind of some common mnemonics that he might mention. The first one is just, SIRS, which is systemic inflammatory response syndrome. You have your criteria, which is, temperature, heart rate, respiratory rate, white blood cell count. If you have 2 of the 4, you meet, SIRS criteria. So you would be SIRS positive if you have 2 of the 4. SIRS plus a suspected infection. So you have an infiltrate on chest x-ray with cough. So you're suspecting pneumonia, would be sepsis. Severe sepsis is organ dysfunction. You need 2 organs to be dysfunctioned. So that might be like an AKI with a little altered mental status. Remember, altered mental status should be coded as encephalopathy in that case, because altered mental status is not an organ dysfunction. Encephalopathy is, for whatever reason. And then you have septic shock, which is just sepsis plus hypotension despite adequate fluid resuscitation. Remember, our fluid resuscitation. Ooh, said that funny. Our fluid resuscitation is that 30 cc's per kilogram of body weight. And hypotension here, or this shock statement. Remember, that's organ hypoperfusion. It's not necessarily a blood pressure. And you can have little ladies with a blood pressure 90/60 up running marathons. You can have big old guys with a blood pressure of 110 over 70, and every organ is failing in their entire body. So remember, this is organ hyperperfusion, not necessarily a specific number. And this is just what SIRS is. I'm not going to go into like sepsis treatment or the early goal-directed therapy, but if you get asked, what is SIRS, this is kind of the stuff you need to know. So also something that's new is the SOFA score. Dr. P will talk about this pretty much every time he mentions sepsis. So he'll first talk about SIRS because this is kind of how we need to be documenting, at least for right now, per the new sepsis guidelines and stuff like that. I believe it will all kind of transition to this SOFA score and the Q SOFA, which is just a quick SOFA. And here is the SOFA score. So what makes it up? You have a kind of a different organ systems that are involved. Respiratory, neurologic, cardiovascular, hepatic, hematologic, and then renal. And this requires an ABG to calculate. So we've got to have an ABG to get this one. And it's just your PaO2 to FiO2 ratio. If you don't know what that is, just kind of look it up. It has to do with kind of ARDS type stuff. This is mechanical ventilation. This can be like BiPAP. At least as far as I think this can be BiPAP. I think it's any form of mechanical ventilation. I don't think you necessarily have to be intubated. Because you can have a PaO2 to FiO2 ratio less than this on someone that's, a DNI, which is do not intubate on BiPAP. And I believe that counts as a SOFA score. And also with SOFA score, this is a change from baseline. Remember that some folks have, chronically bad numbers. So this is a change from baseline. So let's say if they have a baseline of 5, and now they're admitted to the hospital with a 9. So that was a 4 change from baseline. Those type things. So, here's our neurologic status, which is Glasgow Coma Scale, the components involved in that. Cardiovascular stuff, it's just our MAP, MAP less than 70, and then, are you on any pressors here? Our bilirubin, how elevated is it, which is just a sign of organ dysfunction in the liver, hepatic failure, those type of things. Platelets, remember our platelets are going to kind of start falling as we go into DIC, sepsis, and it's also just another sign of organ dysfunction. Bone marrow is not generating platelets or red blood cells or white blood cells, those type of things as we kind of start to gets sicker. And then our creatinine, what's our creatinine and stuff like that. Remember, our creatinine might be chronically 5 in someone with, end-stage renal disease, but they might not be in the hospital, even though they might have a, SOFA score of, let's say they have end-stage renal disease as well as, I don't know, liver disease. So they have a, SOFA score of 4 plus 2, so they have a SOFA score of 6. Remember, that could be their baseline. They might be hanging out at home like that. So this is what goes into the score and how to calculate it. Why is it important? Basically, the more points you get, the worse you do. And just kind of here's the projected mortality associated with the different SOFA score numbers. It's just taken from, I believe, MedCalc. They had a little chart, and I just kind of transitioned the numbers in. So just kind of look at it and just know that, lower is better, higher is worse. People we see in the ICU all the time kind of fall in this range. We'll get some of these folks even on the floor because once again, it's pretty easy to get a kind of low number if you're just kind of a chronically ill person. So here's our Q-SOFA. Remember, if you get to kind of 2 of 3, you need to start evaluating for, sepsis in general, meaning you need to get full lab work and all that kind of stuff like that. And it's just, blood pressure, respiratory rate, and mental status. Not too hard there. Moving on from there, we're going to talk about basically, Dr. P's move stupid mnemonic for encephalopathy or, altered mental status. It's easier to say altered mental status. Remember, altered mental status shouldn't go in the document. Encephalopathy should go in the document. And so, that's acute encephalopathy, which can be due to a bunch of different things. This is kind of some of the things that can cause it, which, metabolic oxygen, usually that's low. Volume, hypervolemic, and maybe CHF or something like that. Electrolytes, potassium, magnesium, calcium, sodium. Sodium's a pretty big one there. Sodium can be, if it's super low, it can make it a little confused. Seizures, steroids. Remember, steroids in general just can cause confusion. Toxins, tumors. Toxins, it can also kind of go down here in drugs. It can also go with intoxications, but you get the picture there. And then your uremia or renal failure, infections, just having a UTI can make you a little confused, especially if you're a 90-year-old lady. Those type things. So this is just commonly used mnemonic. Move stupid for encephalopathy or altered mental status. Going on from there, we have the Pirates mnemonic for AFib. This is just kind of common causes of AFib, which is a PE, pulmonary hypertension, just ischemia in general. So they had an MI, rheumatic fever, rheumatic heart disease, and here's acute MI again. Ischemia, this could be like a instemia, that type of thing. There's a lot of different things for the ischemia, but acute MI, thyrotoxicosis, toxins again. Are they on? Did they overdose on meth before they came? Those type of things. Alcohol, remember, kind of holiday heart, and those type of things. Sick sinus syndrome, electrolytes, potassium, sodium, all those things that kind of mess up the conduction abnormality. Calcium is a big one there. It's just that acronym or mnemonic if he asks about that, so you can kind of know what he's talking about there. Our CHADS 2 score, remember, if you have 0 to 1, aspirin's okay. Greater than 2, you need to be on anticoagulation, which is either with the novel or warfarin or Coumadin. And here's just the kind of the components. CHF, hypertension, age greater than 75, diabetes, stroke, or previous TIA. And once again, the one I said we probably should be using more, it's a little more accurate, is the CHADS VAS, with the VAS being vascular disease, age, and then female. So just remember, if you're, a lady that's 76, so, a female that's 76 with AFib, and that's all you have, you already get 3 points, so, you already need to be on full dose anticoagulation. But remember, all this should be, looked at clinically. You should look at the patient and their also bleeding risk. So don't just blindly put everybody on anticoagulation, especially if they've had like 17 GI bleeds in the past and stuff like that. So going on from there, the curve 65. This is kind of what we use sometimes for pneumonia. It will be on your board exams. They kind of like this to signify should you do outpatient treatment versus inpatient treatment versus ICU. Here's kind of the things that go involved, which confusion, uremia, respiratory rate, blood pressure, and then your age. The pneumonia severity index, so pneumonia severity index is much more accurate and what we really should be calculating on our patients once they come into the hospital. But this can be kind of done in the emergency department to say that they need to come to the hospital. I know I've seen, CURB 65 scores of 1, which basically says you can treat them as an outpatient, and then them be admitted to the MICU because their pneumonia severity index was, I don't know, I think greater than 150 is really bad or something like that. Anyway, it was really high. So, and they needed to go to the MI, and they really did because respiratory rate greater than 30 is on here, but hypoxia is not. So you can be hypoxic at 80% on room air when you're normally 100 secondary to pneumonia. You need to be admitted and might need to consider BiPAP or something like that because it's full on respiratory failure, those type of things. So going on from there, kind of our secondary causes of hypertension. It's kind of OCRAP mnemonic, which is obstructive sleep apnea, hypothyroid, coarctation, Cushing's, oral contraceptives, renal artery stenosis, renal parenchymal disease, aldosterone, pheochromocytoma. We talked about this recently in one of the hypertension lectures, but here's the CHAPS mnemonic, the Spade-K mnemonic. You can kind of read and see what's there. And then this is the one that I kind of liked that was from the Purple Book, which is just endocrine, renal, and other. And you see stuff listed there. And then I also included, the easy screening stuff that we do on a normal basis. So I want to look at how to read chest X-rays. Dr. P will always talk about how we want to read these chest X-rays, and he'll do this A, B, C, D, E, F, G, basically, the ABCs. So there's I here. Should be an I. So, but anyway, A is just assess the quality in the airway. So is the airway midline, or is it not midline? Is it kind of kinked over here to the side? Because they have a big tracheal mass, or is it midline or not? So assess the quality. Good inspiratory effort, over penetrated, those type things. The bones, any fractures that you see, the cardiac silhouette, big, not big, that type of thing. Diaphragms, effusions, is one hemidiaphragm elevated, which could be due to atelectasis, or it might be due to phrenic nerve injury, those type things. Fusions, do you see any fluid, kind of little fissures out here, do not, those type of things. Remember, if we're looking at, let's say we're looking at a lung, and here's going to be my rudimentary lung. Remember, an effusion has more of a meniscus, so you might see something like this. So, and all this being kind of darkened in, so this would be kind of like fluid, versus a pneumonia, which is going to be kind of more of a straight line, more of kind of a low bar distribution, as opposed to just kind of fluid surrounding them. So lung fields, do you see anything, any infiltrates, stuff like that. Great vessels, the hilum, the mediastinum, and then instrumentation, then your final impression. So this is kind of just the general walkthrough that he'll talk about. Going on from there, you have your EKGs. I'm not going to talk about all the different intervals or anything like that, but this is just kind of steps he likes to know. First three big things are just the rate, rhythm, axis. So you want to do that first. Doesn't really matter what order you do on this, but just this is what you want to happen first. Then from there, he just walks through, the EKG itself. If you just kind of think about it, so he talks about the P wave, then you have the PR interval, you have the QRS, which has its own components. Then you have the ST segment itself, because we're going to be looking for elevations or depressions. Then you have the ST interval itself, which actually goes out to here. Then you have the QT interval, and then you have the T wave. So he just looks at the different parts there, and that's basically just how you approach looking at a ECG or EKG, and if you do this kind of stepwise approach every single time, it's kind of what he'll be looking for. So, and there's lots of good resources out there. The one I like the best is the Life in the Fast Lane. Some really good stuff there. For hyperkalemia treatment, it's just the C big K drop is the one I like, with the drop standing for dialysis or diuretics. Calcium, remember calcium is used to kind of stabilize our membranes. You do it when you see EKG changes or ECG changes, and like peak T waves. So if you see peak D waves, you can give calcium to stabilize membrane bicarb, insulin, glucose. Remember these are kind of given together. KXLA can also be given. Also, your beta adrenergic, beta agonist, so albuterol, those type of things. So I left that one out. So your beta agonist. So calcium, bicarb, beta agonist, insulin, glucose, KXLate, and then dialysis diuretics. So then our causes of increased anion gap, metabolic acidosis is most of us kind of heard of the mud piles there. Won't go into a ton of detail. For ARDS, making the diagnosis of ARDS, you kind of need to meet these three things, which are pulmonary capillary wedge pressure less than 18. That just basically means it's not CHF. That's all we're trying to basically say. So it's not CHF. The PaO2, I think it's ratio. It's supposed to be ratio. PaO2 to FiO2 ratio less than 200, and then a chest X-ray with bilateral diffused airspace disease. And it says effusions. Effusions is usually not so much. It's usually just bilateral airspace opacities. So you can find a lot of good stuff, just if you type in ARDS on the internet, in Google, on kind of how to establish the diagnosis, what it looks like on chest X-ray, those type of things. AA gradient, remember it's our alveolar to arterial gradient. Breathing room air is kind of our basic formula that we want to use. Just want to kind of present it there. So if you're ever asked to calculate it, sometimes if we get an ABG and Dr. P's not sure what's going on, he might ask, have you calculated an AA gradient? Those type of things. Last but not least, just kind of some things that we want to think about. Increasing oxygenation, FiO2 and PEP, ventilation, which is, remember, that's our CO2. Remember, we can adjust CO2 by the respiratory rate and tidal volume. There's a lot of other things that you can actually do to manipulate these values. But as a student, this is kind of where you'll head. I think that pretty much wraps it up for this little talk. A little longer than I intended it to be, but hopefully it'll be a little helpful. So, thank y'all.